सुखिनः सर्वे सन्तु निरामयाः सर्वे भद्राणि पश्यन्तु मा कश्चित् दुःखभाग् भवेत् न त्वमेव कामराजं न स्वर्गं न पुनर्भवम् हमें दुख ताका
Good morning, everyone. So today's scientific session on 6th of September will be held today at Sagar. Dr. Jayshree and Dr. Pratibha. Our speaker is Dr. Imran Akhtar, who is a consultant at AIMS Gorakhpur. He is currently practicing in Gupta. Sir has done his MBBS from KGMC Ratna and his orthopedics from MLBMC from Jhansi. He was a sports injury senior resident in Sharpmicrosys, Delhi, and he was an assistant professor in BRD Medical College. I would like to invite sir, and he is also the executive member of UP Orthopedic Association. So I would like to invite Dr. Imran sir to follow up with the topic understanding pathological fractures, causes, diagnosis and treatment. Please sir. Thank you.
Hello. First of all, I would like to thank GP Association, respected President Dr. Jayshree, Secretary Dr. Gupta, Scientific Secretary Dr. Agrawal, and all the senior members of GP Association for giving me this opportunity. It's as you know most of the things of this topic. There is nothing new, just is a matter of discussion. And today we will discuss pathological fractures. Usually orthopedic surgeons encounter most of the fractures, but there are many fractures in which there are a lot of hidden stories behind it, not only trauma. So whenever you see a fracture in which the fracture line is not visible, then we should suspect that pathological fracture. So a pathological fracture is a fracture in an abnormal bone. The bone is usually not normal, and it is weakened bone predispose the patient for failure during normal activity or after minor trauma. But even after a minor trauma, just a slip on the floor or just turning from a center table, and just simple things can cause trauma. Underlying cause can be osteoporosis, metastatic cancers, primary bone tumors, osteomyelitis, Paget's disease, osteogenesis imperfecta, and most of the causes can be classified as correctable and non-correctable. Correctable causes can be renal osteodystrophy, hyperparathyroidism, osteomalacia, disused osteoporosis. These can be correctable. Something can be done to treat these causes. And uncorrectable causes are osteogenesis imperfecta, polyostotic fibrous dysplasia, postmenopausal osteoporosis, Paget's disease, and osteopetrosis, which is marble bone disease. So, among the metastatic causes, the most common primary sites are breast, lung, prostate, thyroid, and kidney. So, whenever we suspect that this fracture has caused due to any metastatic lesion, so we should think of these structures, and we should think investigation according to these structures, primary lesions, and we should investigate and we should examine according to this. So the common sites of metastasis in the bone are spine, pelvis, ribs, skull, and proximal femur and proximal humerus. These are the very common sites in which we should suspect that if there is a pathological fracture in these sites, in the spine. Whenever a patient comes with a back pain, you see a vertebral column which is collapsed. So we should always suspect when a patient is more than 40 years of age and with a back pain, we should not consider a back pain that simply that maybe it is a simple case. Whenever a 40 plus individual has a chronic backache, about more than 1 month, we should suspect of any metastatic lesion. Similar is the case with recently a surgeon referred to me a patient whom he operated a breast lump, a small breast lump, and she came with a shoulder swelling, that there is something pain and swelling. So I did MRI and it came out to be metastatic lesion in the shoulder with severe metastasis of all the structures near the shoulder, scapula and everywhere. So it is very common in shoulder also. Recently I encountered such type of patient. So symptoms can be simple like that of fracture, but the symptoms can be milder like pain, swelling, bruising, and difficulty in using that affected limb. The history, usually the degree of trauma. We have asked that trauma has occurred, but sometimes patient falsely related that injury to a trauma. He says that there was a trauma, then he got pain. But if we take proper history, that do you have that pain earlier also? Then he or she will say that, oh yes sir, I had pain 2 months back in the same part of the limb, but I had some trauma also after that. So sometimes patient relates that usually even in benign or malignant lesions of the bone also, and also in tuberculosis bone also, patient relate that with the trauma. So sometimes that history is false. So we should investigate. We should ask that how the trauma had occurred, and is that problem had earlier also or not. Then presence of prodromal pain, like dull aching pain to intense pain. So as you all know, you are all our clinicians, that we must take all the headings of pain, like onset, severity, aggravating, relieving factors, and all that you all know. And exacerbated by weight bearing, the pain exacerbated by weight bearing. Previously diagnosed or treated cancer, past history of cancer should be taken, past or history of any radiation therapy should be taken. Then we should take history of constitutional symptoms, weight loss, fever, night sweats, fatigue, and various investigation. We should first think that what should be the cause. Then according that we should investigate. X-rays are the most basic thing, and sometimes fracture is not visible in X-rays. Most of the even in distal X-rays we cannot see fractures. Some minor fractures are not visible on X-ray, so we should do a CT, and whenever we should suspect a lump type or a benign malignant or tubercular like thing, we should suspect. We should do MRI also. The aim is to identify the location of the fracture and determine the underlying cause. So fractures suggesting the pathology of fracture, whenever there is spontaneous fracture, even without trauma, or fracture after minor trauma, or pain at the site before the fracture. The patient says that before the fracture he or she had pain. Multiple recent fractures on the same or other limbs also. Unusual fracture pattern. Usually a fracture occurs either straight or oblique, but when the fracture pattern is the look of the fracture is very unusual, then we should suspect this. And the patient, if it is older than 45 years age, and whenever there is history of malignancy, we should suspect pathological fracture. And among examination, whenever there is the swelling, usually the swelling of the fracture in pathological cases, the swelling is not normal. Whenever there is a fracture in a normal bone, there is a pain, redness, and swelling of that limb. But whenever there is a pathological fracture, usually there may be a palpable mass around that fracture. That may be a hard type or soft type. You can palpate and think of what it can be. And identification of obvious deformity should be done. Neurovascular examination is very important. Distally, we should at least ask that there is numbness or not, there is tingling or not, distal to that fracture. And evaluation of possible primary sites like breast, prostate, lung, and thyroid, and lymphadenopathy. And among the lab investigation, all the basic investigation should be done as you all do in your patients, like CBC, ESR, serum electrolytes, blood urine nitrogen, serum glucose, LFT, total protein, albumin, calcium, phosphorus, and alkaline phosphatase. So these are investigations are somewhat related to the pathological fracture, and these should be done routinely to rule out other causes. And we should suspect anemia, hypercalcemia, and increased alkaline phosphatase, then if investigation, if you see these things, then you may suspect metastasis. If the serum and urine electrophoresis, you see Benz-Jones proteins, then you should suspect multiple myeloma. And if there is microscopic hematuria in the urine, then you should suspect renal cell carcinoma. And various other markers which you can do is TFT, CEA, CA125 and PSA for prostate, and telopeptide and C-telopeptide are markers of bone collagen breakdown measured in serum and urine. And we should confirm increased destruction caused by the bone metastasis and measure the overall extent of the bone involvement and assess the responsible of the bone to bisphosphonate treatment. So this chart is very important, and this chart says that usually when you do investigation of serum calcium, serum phosphorus, serum alkaline phosphatase and urine calcium. So these are very common pathological fracture causes like osteoporosis, osteomalacia, hyperparathyroidism, renal osteodystrophy, Paget's disease and myeloma. So in osteoporosis, you see the first horizontal thread. In osteoporosis, all these parameters are normal. And in osteomalacia, this alkaline phosphatase is high. Other things are low. In hyperparathyroidism, serum calcium is high, the phosphorus is low, and alkaline phosphatase is normal, and urine calcium is high. In renal osteodystrophy, the serum calcium is low, serum phosphorus is high, and alkaline phosphatase is high. In Paget's disease, you see hydroxychloroquine. In myeloma, you see light chains in urine. So whenever you see a lytic bone lesion, you should take history. You should review all the other systems like GI and other systems. You should do physical examination accordingly, and you should do all the basic radiological and biochemical tests. And whenever you suspect, you should do biopsy also. Associated medical problems, you should see that whenever there is limitation of activities or daily living due to pain, pathological fractures, neurological deficits and paralysis in spinal fractures, in spinal fracture you should suspect that neurological deficit is there or not. In prolonged recumbency, predisposed to hypercalcemia. Whenever the patient is bedridden for a long time, it predisposes to hypercalcemia and bone loss. And whenever there is anemia and hypercalcemia of malignancy, the prognosis is poor. So whenever a bedridden patient or in malignancy, whenever there is hypercalcemia, you should see these symptoms also, like neurological symptoms of hypercalcemia, headache, confusion, irritability, blurred vision, and GI symptoms are anorexia, nausea, vomiting, weight loss, constipation, abdominal pain. Musculoskeletal symptoms are fatigue, weakness, joint and bone pain, and unsteady gait. And urinary symptoms are nocturia, polydipsia, and polyuria. And the level of hypercalcemia does not always correlate with the severity of metastasis. Vigorous volume repletion, treat the tumor directly or bisphosphonate to reduce the osteoclastic activity. All biochemical parameters should be correct prior to surgery. So, Henneking's classification is there to classify the lesion, that where is the lesion, either it is epiphysis, metaphysis, diaphysis. Diaphysis is in the middle of the bone, epiphysis is the end of the bone, and metaphysis is in between. So where the lesion is in the cortex, or cortex is the bone margin, and medulla is in the between. Either it is in long bone or flat bone. We should think of what, as a clinician, we should think that according to the lesion, what the cause can be according to the structure of the lesion. What is the bone doing in the lesion? Like, is the lesion is a well-defined reactive rim? Then if the lesion is well defined, the margins of the lesion is very clear, then it is a benign lesion. If it is intact but abundant periosteal reaction is there, then it is an aggressive lesion. And when the periosteal reaction is that cannot keep up with the tumor, that the bone margins are not clear, and if the lesion is expanding beyond the cortical margin, then it may be malignant. Then clues for the tissue type is if calcification is there, then it can be a bone infarct or cartilage tumor. If ossification is there, then it can be osteosarcoma or osteoblastoma. If ground glass appearance there, then fibrous dysplasia can be suspected. Entire bone imaging should be done. If you see a fracture, suppose in the humerus, proximal humerus, then you should do X-ray of entire bone from one joint to the other joint. So nearest two joints should be investigated. So suppose you see proximal humerus fracture, but this is not a normal fracture. And then obviously you see that the cortical margins medially are breached. There is a lytic bone lesion, and this is a normal fracture. This is not a normal fracture. Patient may suspect that I have got injury and then fracture occurred, but this is not normal. We should suspect of metastasis or hyperparathyroidism, hypercalcemia, and other things which should be ruled out, and we should investigate about. We should do CT also, MRI also. And at the right side you see femur. There is a lot of periostal reaction, and this is also not a normal fracture. And osteopenia indicates inadequate bone or inadequate mineralized bone is osteomalacia. So when osteoporosis, the bone is not inadequate, and osteomalacia, the mineralization of the bone is poor. When you see looser lines or compression site, reducent lines, calcification of small vessels, pharyngeal periostal reaction, we should suspect either osteoporosis or osteomalacia, and signs of osteomalacia or hyperparathyroidism should be ruled out. You see in this X-ray, there is the cortical margins are thinned out, the trabecular pattern is lost. Then we should suspect osteoporosis in the spaces in the simple X-ray also. And permeative or moth-eaten pattern of the cortical destruction is highly suggestive of malignancy. Whenever you see moth-eaten appearance, whenever you see that something has eaten of the bone, then it should suspect a malignancy. When the age is more than 40 years, malignant carcinoma, myeloma, and lymphoma should be suspected. We should perform biopsy for lytic lesions. Solitary bone lesion of patient with or without history should be done. Needle biopsy is definitive when differentiating carcinoma from sarcoma with adequate immunohistochemistry. When there is pathological fracture through the lytic lesion, bleeding can occur due to early fracture cases. Thus, these fractures should be stabilized first and then biopsy undertaken. Biopsy should be obtained from a site near but unaffected by the fracture. The biopsy should be taken not from the fracture, and the site should be as small as possible. Longitudinally in line with the extremity, tissues involved in post-biopsy hematoma must be considered as contaminated. Cultures for all biopsy to rule out infections that may mimic tumor on X-rays. If a definitive diagnosis present on frozen section intra-op, then ideal to fix the fracture, otherwise wait for permanent section. Impending pathologic fracture. We should know the skeletal mets usually treated by radiation, chemotherapy, and prophylactic fixation. These all things should be done in skeletal metastasis. Radiological assessment of the lesion in patient's symptom necessary to calculate the risk. Fracture risk is greatest during the patient positioning, preparation and draping, and we should do decision making according to these headings. We should manage, we should treat the local bone cause, surgical stabilization, either resection should be done, radiation if required should be done, functional bracing should be done if required, bisphosphonate may be added. It inhibit osteoblast mediated bone resorption, and whenever we do surgery, antibiotics perioperative is essential. Thromboembolic prophylaxis should be done. Nutrition should be taken care of, and all the pulmonary exercises and early mobilization should be done in cases. Bracing should be done whenever we cannot do surgery due to comorbidities, and we want to do palliative treatment, and bracing can be done for such lesions. And in surgery, we do various type of fixation. We do sometimes bone cementing is done. Goal is to stabilize as much as bone possible. Suppose in this X-ray, we should think either to replace it or you want to save it. If you want to replace it, you replace the complete whole thing, like in this proximal humerus, everything is replaced and a humor prosthesis is applied. And on the right side, we have conserved it by a nail. So the take-home message is early diagnosis, etiology should be searched, comorbidity should be taken care of, treatment of underlying causes should be done, and we should stabilize the fracture. Now this is a case, this is my case recently done 15 days back. So this lady is a 70-year female. She came here to me 3 months after fracture. She said that just I am unable to walk for 3 months, and just I turned from a center table. Then after that I am not able to walk. So when I did X-ray, then I saw such a fracture and lot of overlapping of bone. You see bone is overlapping is too much, and if you watch clearly from near, then you will see lot of callus formation also is there. New bone formation is also there. So such bones are very difficult to manage and reduce. So we should just not only try to fix the fracture, we should search that why it occurred. Maybe it is a metastasis, maybe it is a osteoporosis, and we should search all the causes and we should treat them accordingly. Then I operated her. I have not opened the fracture site. I use this is a big instrument. I apply pin over the proximal and distal part of the fracture through this instrument. And this instrument distracts the fracture, and I have done this case without opening that fracture. So this was the post-op X-ray, in which without opening that fracture, this nailing is done, and lot of screws are applied proximally and distally without opening the fracture. Luckily the lady is doing good, but it is only 15 days have passed. So maybe the bone will unite. This is the AP and lateral view of the right side of the limb. So just to show that patient usually even ignores a fracture also. The lady living in the heart of the city, he has ignored the fracture also. So the treatment approach, it can be either managed conservatively or surgically. You have to decide according to the patient condition, and we should manage the underlying cause. And surgical intervention should be done. Usually such type of fractures have a poor callus formation. All these pathological fractures have a poor callus formation. Even after good fixation, you may see a poor callus and a poor healing. The healing of the tissues are delayed, and these fracture can reoccur. Even after best fixation, a fracture may occur on the both end of the implants also, on the proximal or distal ends of the implants also. A refracture can occur, or re-metastasis can occur. So the prevention should be done by managing the underlying condition, and medication and lifestyle changes should be done, and bone health measures should be done. Patient education is very important. Regular checkups should be done. Multi-speciality approach is important. Early intervention and monitoring is important. So the take-home message: pathological fractures may be a tip of the iceberg. Thorough history, examination, and investigation is essential before treating. And stabilization of the bone and treatment of the underlying cause is the key of the management. Thank you.
Thank you, Dr. Imran, for giving such an elaborate discussion about the fractures. Apart from trauma that you have enlightened us to inquire about other pathological diseases and other associated factors also. Very informative and good for general education.
Any queries?
Imran, I have one question. As a surgeon, see the pathological fracture, it happens with the osteoporosis also and malignancy also. So what is the things to be discussed and to be to mark in the X-ray? How you decide this is the osteoporotic or this is a malignancy?
So the most basic investigation, when your patient comes, you do X-ray. This is the most basic thing.
How does it look in the X-ray?
Yes, sir. So when you see X-ray, so a fracture, you must first, the most important thing you should appreciate that the bone has been broken, either undisplaced or a displaced fracture. Completely bone is separated. So when the fracture margins are sharp, then this may be not due to the malignancy. And whenever there is a malignancy, either primary or a secondary, there is a moth-eaten appearance of the ends of the bone. Usually some insect has eaten that, suppose that bone. So there is a moth-eaten type of appearance. Number one thing. Second thing, that the cortical margin of the bone in a simple X-ray, you see most of the cortex are usually straight or a slight curve. The cortical margins are usually not normal. The cortical margins are either eroded or expanded, or a lot of different types, like in osteoclastoma and all that, sun ray appearance, and lot of things are described. So second thing is the cortex. The cortex is thinned out, either thinned out or the cortex is expanded, and you see a bone lesion also, or bone expanded bone, or whenever there is severe malignancy or metastasis, the bone, the cortical margins are completely breached, it may be breached. So in that cases, whenever there is a confusion, the most important investigation after this is MRI. Because only an MRI can identify that this is either due to a malignancy, or it may be a tubercular lesion, or other causes. So MRI should be done.
Few things I would like to add. It's a nice presentation, Dr. Imran. And there are certain things in metastatic lesion which Dr. A.B. Gupta was asking. You will always find necrosis type of thing around the fracture site. It will never be clear cut. Number one. Number two, mostly medulla part, not the cortex, medulla part is affected in malignancies and metastatic cancer. So you can differentiate with that. Another thing I want to add that in case of multiple myeloma, which is nowadays I am finding very common, people come with pain, simple pain, body and fracture. Now how to differentiate with the other malignancies, multiple myeloma, very clear. You should always ask flat bone X-ray, and best flat bone available is skull. Go for the skull X-ray. You may not find very much punched out lesion in peripheral bones, but in skull bones, you will definitely find. And that is a diagnostic feature. Then you may not find, even if you do FNAC or biopsy from the local site, you may not find anything, myeloma cells. Still you have to search. So go for the ISC. Urine you may not get based on protein. And always have a doubt in mind. Whenever patient come to you with body or pathological fracture, think of that also. No matter how destructive the disease is, it is curable. You will find a lot of metastatic lesion, osteolytic lesion, punched out lesion in the spine. Patient is bedridden, he is not able to walk. But still with the chemotherapy and localized radiation, patient is able to walk, he can survive for a pretty long time. So this is the situation. Don't think that no, ye marne wale mein iski die. What is the survivor thing? 5 to 7 years they go ahead. And if properly maintained, most people, they are surviving very well. So this is another thing. Another thing is, bone itself is causing pathological fracture. So any osteogenic sarcoma, living sarcoma, that can lead to fracture. Apart from metastatic lesion. So this is another thing. So thank you, very nice presentation.
Thank you, Dr.
What should be the preventive measures?
Preventive measure, as the most common cause of pathological fracture is osteomalacia, second is osteoporosis. So the most important preventive measure is to prevent osteoporosis and osteomalacia. And for prevention, the most important thing is nutrition is the most important thing from the early days of the life. And other than nutrition, exercise and lifestyle changes should be done. Nutrition is the most basic thing. Nutrition is the 75% is nutrition. The nutrition should be better from the starting days. And among the nutrition, the most important thing is calcium and protein-rich diet should be given. And other than this, various other vitamins also help. So calcium and protein-rich diet should be given. And among the lifestyle changes, physical activity should be high. So we should make ourselves keep walking. Whenever you see 4 or 5 patients, you start walking, and you see patient while walking and standing. But you should not keep sitting, because sitting is a very harmful for our back and gluteal regions, and thigh wasting usually occurs in sitting. So the muscle should be strong. And for that, you should either you do exercise or you should be involved in sports activity. So these are the lifestyle changes. And and this was for osteoporosis and osteopenia. And for this metastatic and benign lesions, the most important key, as you all know, is the early diagnosis. When you can do early diagnosis, and that is the only winner part. So a patient who has been diagnosed early, only that patient can be treated, as Dr. Chaturvedi has said, that we should pick the tumor, either benign or malignant, like in multiple myeloma he has said. And so the early diagnosis is most important for this malignancy and benign or malignant tumor part. And for this infection part also, like in tuberculosis, very common, tuberculosis bone is very common in our day-to-day practice. We should always think that whenever a patient comes with some infection type of thing, or suppose their infection is of more than 1 month of any limb, then we should suspect either a tumor or tuberculosis, or we should suspect an immunocompromised state, and we should investigate accordingly. This was for the infective part. And the basic thing which orthopedicians are taught, that whenever there is a pathological fracture or any such type of lesion, we should think of 3 T's, either trauma or a tumor or a tuberculosis. So 3 T's are most basic things which our orthopedicians are taught: trauma, tumor and tuberculosis. These are 3 T's which are very important. We should think accordingly.
Very important investigation, I think, for the osteoporosis. This BMD is a very important investigation, and this is for the prevention also. If you do the BMD test, you can in osteoporosis, you can diagnose the osteoporosis very well.
Every individual in more than 40 years age, BMD should be done yearly. Every year BMD should be done for ourselves also and for our patients also.
Which calcium, which again so many combinations, so many companies are coming. Actually, which calcium is okay?
I think one basic thing I will like to say that since we have been exploded by a lot of companies, so the most important thing that the company should be very standard, high standard, and of good quality. This is basic thing. You can this is very basic thing which we encounter. That the company should be reliable and it should be of good quality. This is the most important thing. Because even if you see that even you give calcium carbonate to the patient, but if the company is good, then it will benefit the patient. So coming to the molecule part, so molecule part, the calcium citrate maleate, usually people say that this has the most increased bioavailability. That bioavailability of calcium citrate maleate is better, and lot of combinations are there, but these two things should be taken care of a good company. And calcium citrate, even you can write calcium carbonate also, calcium citrate maleate also, and but that is not, I think, I have seen in my practice that it does not make much difference. We should first think that what is the calcium requirement of this patient. If the calcium requirement, as you all know, the daily calcium requirement, and we should give calcium accordingly. We should see that on the wrapper of this that what is the elemental calcium in that, and according to the elemental calcium we should give to our patients.
One question. See, Dr. Mahendra Agrawal sir had said very rightly that one should go for the BMD. So there was one camp organized in the Sitapur Eye Hospital that time when I was IMA present. So mostly our doctors have gone through that. Many people have the deficient of the calcium. So I request Dr. Imran as an orthopedic surgeon, please suggest us, all doctors and even the gynecologists, lady doctors, what companies calcium one should take. Either usually we prescribe one OD, 500 milligram, one OD. What should the proper dose? How much it get absorbed by availability in the body? So please suggest us, all of us, So what calcium should we take? And even we can say the name of the company also, because we are ourselves, all are doctors. So we can
So when a PMD camp you have said, in my early practice days, to increase my patients, I did PMD camps. But I realized in 4-5 years that I am doing this wrong to the patients, because lot of patients have a psychological problem after that my bone is weak, So I have stopped this PMD camp thing, because in PMD camps the modality which we use is ultrasound probe modality, which gives a wrong reading every time. We should not entertain this pharma company people to do this camp, because this gives wrong message to the society, just to build a mob which we do this. So the standard BMD is what is a dual energy X-ray X-ray, DEXA. So the DEXA is what is that is actual like an X-ray machine. So that is a static thing, it is not a portable thing. The portable BMD is not good. We should not do in our clinics. That is one thing. And second, sir has said that what dose, as you all know that the daily calcium requirement is around 1200 per day calcium. So in that thing I want to say that calcium is one thing that we can take from our diet also and from medication also, and vitamin D is other thing. We get only combinations in market, that is other thing. So the most important among this is if the patient has no, ourselves or any patient has no any comorbidity is there. So the first important thing is our vitamin D level should be good. So how to maintain this vitamin D level? The serum vitamin D level should be more than 50 international unit. And whenever you see that it is less than 10, then we should categorize as it is a severe vitamin D deficient patient, and we should increase the dose of vitamin D. But usually normal in our healthy life, we should, all of us, in ourselves and family also, we should take 60,000 unit vitamin D weekly basis for 2 months, and after that we should take this 60,000 unit on monthly basis, because vitamin D is a fat soluble vitamin vitamin D is stored in the liver. So I don't think that daily dose of vitamin D is required. Daily dose of vitamin D is not required because it is a fat soluble. It gets absorbed in the normal liver, and gradually that liver secretes whenever we want to absorb calcium from our intestine, then the liver releases vitamin D, and through that calcium is absorbed and it is transferred to the bone. So the vitamin D is a very important thing. All of us we should take, because neither vegetarian nor a non-vegetarian diet is sufficient for vitamin D. That is a very important thing we should take in our daily activity. Now, the second thing is calcium. Calcium should be taken only when first thing, if our BMD level in BMD report, all of us we should do BMD, either orthopedician or non-orthopedician. So in that report only we should see T-score. In T-score we should see that if the T-score is less than -2.5, we should suspect osteoporosis, and if it is less than -1.5, then osteopenia. So -2.5 is the cutoff point. So if BMD, if in a BMD test osteoporosis or osteopenia is suspected, then only we should think of taking calcium. And second thing, if there is any intestinal problem to absorb the calcium, then only we should take calcium. And third thing, that if our diet is not sufficient, or we cannot take a proper diet of calcium, calcium diet should be divided in 3 doses. All the calcium thing that we know that in milk, curd and paneer, and in 3 things we should usually take for the calcium. And these 3 things should be divided in 3 servings. Usually the serving is about approximately 200 milligram is considered as a 1 serving of the calcium. So we should take these servings 3 times a day our body needs calcium from our diet 3 times a day. That is very important. We should take during our clinics also we should take. And first thing, if we cannot take this calcium from our diet, or it is not getting absorbed from our intestine due to other comorbid reasons, then only we should take calcium. And if our BMD is not good, then only we should take calcium. We should not take calcium at, oh, I think my bone is weak and I just started taking calcium. I will take MJ calcium, which is very expensive and very good. And we should not consider any, or we should not stick to any company also. That MJ is very good, Torrent is very good, nothing is good. Yes. And Bhakti is very harmful for anything. That this is very good and this is I only go upon this, that this is the most ideal good thing. So we cannot name a company that this company is very good and we should take up this company. You all are clinicians, whatever to suspect, to identify a company when, for example, a pediatrician writes amoxiclav, a good company, then he should think that, okay, this company, amoxiclav, Cipla is a good company. That means that he identifies that this company is good. Then take calcium of that company. So we cannot say that this company is very good and only that we should take calcium of that. And we should take calcium only in these conditions. Okay. So I think we are dealing. Thank you. Thanks a lot. Thank you. Question number 1. Following is raised in osteomalacia. Which of the following is raised in osteomalacia? Rest of the things are normal. Serum calcium, serum phosphatase, alkaline phosphatase, and urine calcium. मैम ने बोला alkaline phosphatase. मैम ने बोला पहले. निष्ठा. alkaline phosphatase. Okay. Second question, all are correctable causes of pathological fracture. That this can be corrected except renal osteodystrophy, osteopetrosis, disused osteoporosis, hyperparathyroidism. मैंने बोला Third question, most common cancer which metastasize with to bone. Most common cancer. Stress. सबको पता है. Question out हो गया. तो जो बोलेगा हाथ उठा के बोलेगा तो थोड़ा सा एक क्लू मिल जाएगा किसने पहले हाथ उठाया. खाली मुंह ने सच बोला है. क्वेश्चन नंबर 4 ये रहा आपके जवाब. नो हाथ. मोस्ट कॉमन साइट ऑफ मेटास्टेसिस आर ऑल एक्सेप्ट pelvis, proximal femur, ribs, and proximal tibia. हाथ उठा के बोल रहा है. proximal tibia. चॉकलेट पे लेके जाऊंगा. पहले सर मैंने बोला पहले. आप साइंटिफिक सेक्रेटरी हैं. आप बोल के भी आप नहीं सर और मैम ने एक साथ उठाया था. Question number 5, second last question. In hyperparathyroidism, which test may be normal? Serum calcium, serum phosphorus, alkaline phosphatase, and urine calcium. हाँ, मैम ने बोला सही है. सी है. alkaline phosphatase. Last question एक.
पाँच ही है. चॉकलेट पाँच ही है.
Thank you everyone.